I'd like to introduce our next speaker, Dr. Fraser Magee, who's currently the Trauma Fellow at the Alfred Hospital in Melbourne. And Fraser is going to be presenting the influence of Indigenous status on trauma-related intensive care unit outcomes in Australia, a retrospective study. Thanks very much, Fraser.
Thanks, Anthony. Many thanks for inviting me to speak at today's session. It's a big honour for me. First of all, I'd just like to pay my respects to the traditional owners of the land. My paper is on the influence of Indigenous status on trauma-related outcomes after admission to ICU in Australia. Now, some background. The Indigenous refers to the Aboriginal and Torres Strait Islander peoples of Australia, and they comprise around 680,000 people as per the last census, which is around 3.3% of the population. A significant health gap exists between Indigenous and non-Indigenous peoples. This is data from the Australian Bureau of Statistics, and it shows that in both males and females there's around a 10-year gap in life expectancy, and this is not reducing, and part of the government's closing the gap strategy was to reduce this to zero by 2030, but we're not on course to do that. In terms of the cause of death in Indigenous patients are in red on this graph, and you can see that trauma is a major cause of death in this group. By comparison, non-Indigenous patients, trauma plays a far lower role in the overall cause of death. Despite this, the studies in this area have been small. They've been single centre. And this is a major issue. So accordingly, we aimed to investigate the admission characteristics and hospital outcomes for Indigenous and non-Indigenous patients admitted to ICUs after major trauma. The three areas of outcome we were interested in were patient-centred, hospital mortality, discharge to rehabilitation as a surrogate for functional outcome, and admission incidence. This was an ANZICS adult patient database study, and we incorporated data from the period 2010 to 2015. We adjusted for age, we adjusted for Android score, severity of illness, and we adjusted for the remoteness of the patient's postcode. In addition, sites were treated as a random effect. The incidence projections were calculated using the annual Australian Bureau of Statistics population data. This is a pie chart showing the breakdown of Indigenous and non-Indigenous patients. There's been a bit of a formatting issue there, I do apologise, but 12.8% of patients in our data set were classified as Indigenous, with just under 80% of patients classified as non-Indigenous, and in total we had 23,804 patients in our data set. This is the baseline characteristics. Given that this is a trauma data set, patients were young. Indigenous patients were slightly younger than non-Indigenous by around 4 years. There was equal distribution of sex. Indigenous patients were more likely to be mechanically ventilated, and they had slightly higher Android scores. The distribution of chronic disease was similar at baseline. However, Indigenous patients had a lower incidence of cardiovascular disease. This is the breakdown of the trauma subgroups. The ANZICS dataset classifies trauma into 5 different subgroups. So there's isolated C-spine injury, there's multi-trauma with spinal injury, there's multi-trauma without head injury, there's burns, and there's head injury. The distribution was reasonably similar, but because of the size of the data set, the difference between head injuries and burns achieved statistical significance. And the majority of patients were either isolated head or multi-trauma without head injuries. This is the distribution of remoteness, and this is using the Accessibility and Remoteness Index of Australia. And it shows that Indigenous patients were much more likely to reside in a very remote location and much less likely to live in a major city, which isn't surprising. I'm now going to present the primary outcome results of the study. And this is the adjusted mortality data. So after adjustment for severity of illness using ANDROD, age, hospital site, year of admission, there was no significant difference in the adjusted hospital mortality rate between Indigenous and non-Indigenous patients admitted to ICU following major trauma. In blue, this is the discharge to rehabilitation rate for Indigenous and non-Indigenous patients. And you can see that the rate for non-Indigenous hovers between 15 and 20% per year. In red, we have the Indigenous rate, which the p-value at the bottom left-hand corner is a significant difference. Indigenous patients more likely to be discharged to a rehabilitation facility. And this is the admission data per million head of population. Again, in blue, the non-Indigenous patients. So the yearly admission was between 200 and 300 per million head of population. And the Indigenous in red, with an incidence ratio of 6.8 for the whole data set, so almost 7 times more likely to be admitted to ICU with major trauma. So in summary, we found a similar hospital mortality after adjustment for all of the baseline variables. We found that discharge to rehabilitation rates were higher in the Indigenous than the non-Indigenous patients by a factor of almost 2. And we found that Indigenous patients were more than 6 times as likely to be admitted to ICU with major trauma as the non-Indigenous population. There were limitations to this study. It was retrospective. The other major limitation was misclassification. The Indigenous status only became a mandatory component of the ANZICS dataset in 2007. Our data was from 2010. We analysed data both with and without 2010 included to see if it made any difference. It didn't. But this is a potential limitation. The other thing about Indigenous status is that in younger patients, it's been notified that younger Indigenous patients can often not self-classify themselves in Indigenous. So it's possible that we underestimated the number of Indigenous patients in the study. The other major limitation was that although the ANZICS dataset describes the different trauma subgroups, the 5 different subclasses that I outlined earlier, it doesn't document the trauma mechanism, so we had no way of knowing whether these were road traumas, assaults, falls. So it's another limitation. We were also unable to determine what the pre-hospital standard of care was like, how many patients died at the roadside, for instance, what the pre-hospital level of care was like. That wasn't something that we looked at. And we were also unable to discriminate between discharge to a chronic care facility or a nursing home. The rehabilitation code on the ANZICS dataset incorporates chronic care facilities and nursing homes together as rehabilitation, so we weren't able to discriminate in terms of which patients were discharged to chronic care facilities or which were discharged to nursing homes. There were a number of strengths to this study, however. There's a large data set, by far the largest data set of Indigenous trauma patients published to date. It's the first national study in this area. We believe that it's got good external validity within the Australian setting. Our database encompassed over 80% of Australian public ICUs. And we also, although it was retrospective, we adjusted our mortality and discharge to rehab outcomes for the pre-specified variables in terms of age, severity of illness score, hospital location and remoteness. So in conclusion, the health gap that exists for mental health and chronic disease and mortality appears to also be present for major trauma admitted to the ICU. Public health initiatives may be needed to reduce this. And the higher rate of discharge to rehabilitation facilities for Indigenous patients suggests that there may be barriers to discharging this group of patients home. I'd like to thank all of my co-authors, but in particular Ronaldo Bellamo and Michael Bailey for all of the huge help that they gave me in the publication of this paper. In addition, I'd like to thank Penny Stewart and Paul Seacombe from Alice Springs for their input. And I would be happy to answer any questions. Many thanks.
Thank you very much, Fraser, for an outstanding presentation. I might just lay it open to the floor now for questions. Professor O'Leary.
Thanks, Fraser. Look, you sort of put it on your last slide, which was the reasons why, a potential reason why Indigenous patients were more likely to be discharged to rehabilitation, and it's possibly related to the difficulty of them being discharged to home. But one of the ways that you might be able to tease that out would be by looking at their postcode and the distance from their postcode to the hospital in which they were treated. That might give you some information about how many of them were transferred very long distances from the original site of injury, a potential original site. Of course, it doesn't tell you whether they happened to be down the road from the hospital when they got run over, but in general, it might give you an idea as to whether there was a lot of transfer of Indigenous patients in comparison to non-Indigenous. Have you considered potentially doing that?
Yeah, it's a very good point, Michael, and it is something that we did consider. We adjusted the data for postcodes, so we did have that data available. However, we didn't think it was going to add all that much, simply because the inter-hospital transfer rate was similar between Indigenous and non-Indigenous patients at 9%. Okay, so it was something that, and had that been a significant difference, I think it's certainly something that we would have adjusted for and looked more closely at. The reasons for the discharge to rehabilitation rates and the increase in discharge to rehabilitation rates are manifold and complex, and I've done a lot of reading in this over the last few months, and we haven't obviously been able to identify any single issues, but they're likely to be a mixture of social issues and home situation, and although we adjusted for remoteness, we can't fully exclude that as a reason either. And certainly the data that we found is consistent with the research that's been done into cancer care for Indigenous patients in terms of barriers to accessing cancer care in Indigenous communities. So we are seeing a pattern in this now, and I think it's something that we really need to look at and find out what these barriers are and what we can do to reduce them.
And I just one little follow-up thing, so obviously this is an ANZICS database APD-related study, so what was your personal involvement? How much of the work did you do personally?
Yeah, so look, I've been doing work with Ronaldo and Michael for the last couple of years in similar areas, and I've got a background as an epidemiologist. And the reason that we did this was that we'd actually started a paper which I was a co-author on gender-related outcomes following major trauma, which turned into a rather large paper that's now been broken down. But as a result of that, we realised that the Indigenous data was coming to fruition after a period of 10 years of the ANZICS dataset coding for Indigenous, and we thought that it would be interesting to look at this group of patients, particularly as I was starting my position as the ICU trauma fellow at the Alfred. So trauma research and epidemiological research was a major interest of mine. In terms of meeting the actual criteria as a first author, I certainly met the ICMJE requirements as a first author. In terms of instigating the actual idea for the study in the first place, and also the first author correspondence with in getting this paper published.
Thanks for your presentation, Fraser. Do you have any feeling as to whether similar findings would apply in other first world countries with substantial Indigenous populations, such as New Zealand or Canada, or do you think this is a peculiarly Australian phenomenon?
Well, it's interesting that you asked that, because we actually have the data for the Maori population in New Zealand. We decided at the outset to make this an Australia-only study, simply because the Indigenous populations of Australia and New Zealand are very different. So we do have that data, and actually it's something that we're going to look at publishing at a later date, analysing and publishing at a later date, possibly. The outcomes in Indigenous patients, my reading over this in the last few months is that this is a global phenomenon in terms of whether you look at Canada, whether you look at New Zealand, whether you look at any of the societies that have been colonised by European powers, and it is certainly a pattern in terms of whether outcomes are actually worse amongst Australian Indigenous population. I think the answer to that would probably be yes, but I don't have that data to hand in terms of giving a definitive answer.
We've got time for one last quick question.
Thank you for a great presentation. So you mentioned that you didn't have data on the trauma mechanism, but you also mentioned in your conclusions that you thought public health campaigns might be warranted to intervene on some of these statistics and outcomes. So as someone who practices in the system, what do you see as being some of the more common trauma mechanisms, and what type of public health campaign are you envisioning to make change?
Road trauma, I think, is the major area that we would look at. And in New South Wales, which contains 1/3 of the Indigenous population of Australia, they published a document called Road Safety in Aboriginal Australians in December 2014, and they identified a number of factors that could be improved. I don't have time to go into all of them today, but they were patient-specific factors, and in that they identified the fact that 1 in 5 Indigenous car accidents involves an unlicensed driver, which is much higher than the Australian average. They also identified the fact that a huge number of them occurred with unregistered vehicles. Seatbelt compliance is much lower. Drink driving is much higher. There's a number of simple road safety areas that we could look to improve. In addition, in New South Wales, they've enrolled 109 Aboriginal youths in a safe driving campaign, and they're looking to expand that to over 1,000 over the next few years. And they're also looking at improving road infrastructure in rural and remote communities. So a number of things just in terms of road safety. If we look more widely at assaults, for instance, if you're an Indigenous female, you're 35 times more likely to be hospitalised following a family-related assault than non-Indigenous, which is unacceptable in my view in a developed country. And there's clearly things that we can do to improve this.
Thanks very much, Fraser.